Hey, healthcare friends, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you, written in your style and ready the moment the visit is over. All you have to do is give it to your patient. Just imagine leaving the office at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence cannot replace you, but it can do the administrative work that no human should be subjected to. Get back to doing what you love, helping your patients, and let Freed AI do the rest. Hey all, welcome back to the Real Life Pharmacology podcast. I've got 5 more medications today of the top 200. We've got drugs 71 through 75. We've got Robitussin, Valium, Viagra, Bactroban, and Januvia. So stay tuned to hear all about these medications and some of the most highly testable clinical practice pearls that you're going to see on your board exams and your pharmacology exams throughout school. So with that said, let's get into it. We've got Robitussin. Generic name is Guaifenesin, but I will caution you, there are multiple formulations of Robitussin. So classic example is Robitussin DM. So that has dextromethorphan within that product. So biggest thing to know here is to understand when a patient says I'm taking Robitussin, you have to investigate that because you don't know if they're taking it with dextromethorphan, if they're taking it with a decongestant, for example. You don't know if it's just some other generic cough suppressant and they call everything that suppresses cough Robitussin. So really, really important to dig down and figure out what exact product they're using, because I've definitely seen, medications that have first-generation antihistamines in there, such as doxylamine, for example. These can cause all sorts of problems: urinary retention, dry eyes, dry mouth, constipation, even worse than confusion in our geriatric patients. So definitely dig into that whenever you hear patients taking a cough and cold medication like Robitussin. Look and see if you can actually see what they're taking. Educate them about looking at the back of the label and seeing what medications are actually in there. All right, so a little bit more focused on Guaifenesin here. This is an expectorant. It comes in extended release, immediate release. Dosages range from 200 to 600 milligrams per usually tablet. It does come in multiple formulations as well, solutions, things like that. It's a max of 2.4 grams per day. Usually the IR dosing is 200 to 400 milligrams. The extended release is usually 600 per tablet, for example. Usually well tolerated. I do want to mention that the American Academy of Pediatrics typically recommends avoiding using OTC agents for management of cough and cold symptoms. Okay, so definitely something that we should educate patients about from an over-the-counter perspective. Always good to check with somebody when we're talking about infants and toddlers under the age of 2 there. Again, those various formulations, Robitussin CF is another one I wanted to mention. That comes with pseudoephedrine. Pseudoephedrine can have some adverse effects like insomnia, for example, which can be problematic. They can raise blood pressure. So if you got a patient that's maybe not very stable from a cardiovascular standpoint, they've got really high blood pressure, for example, pseudoephedrine might be something that we want to avoid there. So again, pay attention to those labels, pay attention to what product the patient is actually taking. One other important point, if you've got a patient taking cough medicine for an extended period of time, 5 days, 7 days, or longer, I would say, you've got to make sure that they're not taking an ACE inhibitor. I've seen this probably a handful of times throughout my career where patients are continually coming to a pharmacy, or they're reporting that they've been taking cough medicine for months, and they're having a dry hacking type cough. That definitely could be an ACE inhibitor, and we need to make sure to check their medication list, make sure they're not taking lisinopril, for example, that can cause that chronic cough. One other thing to mention as far as maybe drug interaction standpoint goes, generally avoid alcohol, particularly if you're taking a Robitussin formulation with sedative type medications in it, like those first generation antihistamines. That could really make that sedative type property worse. Dextromethorphan as well, if that's in your cough suppressant in your Robitussin type product, that can also have some kind of excessive sedative type properties when we use it with other sedating medications or beverages or whatever the case may be there. All right, next medication is diazepam. Brand name is Valium. This is a benzodiazepine. It potentiates the effect of GABA. And remember, GABA is an inhibitory neurotransmitter. So basically, it's going to kind of, tone down the central nervous system is what a benzodiazepine like diazepam is going to do. So where can we use this? Anxiety, seizures. Occasionally I'll see it for various muscle spasticity type symptoms with patients with spinal cord injuries or MS, for example. I've seen it as well. So those are some of the main indications there. Dosage forms, formulations, it can be, it is available by injection. It is obviously available oral as well. There is a rectal formulation as well that can be utilized for the treatment of acute seizures too. So make sure we know what formulation we're dealing with, and then obviously what the indication is as well. Similar side effect profile to alcohol. That's probably the easiest way to remember it. Sedation, confusion, slurred speech, fall risk. So very, very similar to the effects of alcohol in many respects. From a geriatric standpoint, diazepam has some active metabolites, and those metabolites are generally formed by some of the CYP enzymes. CYP3A4 does play an important role. So, drug interactions with diazepam, let's say compared to lorazepam, there are significantly more CYP-mediated drug interactions with diazepam. So that's definitely a downside to its use. Also, significant active metabolites. So this can be a problem in geriatric patients. Tends to lead towards a longer half-life. It is a longer-acting benzodiazepine compared to some of the other medications within that class. So generally, it's recommended to avoid diazepam in geriatric patients due to that excessively longer half-life in our geriatric folks. So definitely pay attention to that. It's a good reason why we try to minimize the dose and avoid it altogether, because of that reduced clearance and some of those pharmacokinetic principles. A couple other clinical pearls, things that might come up. The reversal agent is flumazenil. There's some details on whether you should use that or not use that in an overdose type situation, but I'm not going to go into that. Definitely flumazenil I have seen shown up on pharmacology exam. It is a potential antidote or reversal agent for benzodiazepines. It is a Valium or diazepam is a Schedule IV controlled substance as well, so we've got that risk of addiction and dependence too. Next one on the list is number 73. We've got Viagra, which is the generic name is sildenafil. This is used primarily for erectile dysfunction, but also can be used for pulmonary hypertension as well. Not something I see crazy often, but I certainly have seen it in my practice over the years. Mechanistically, this drug inhibits phosphodiesterase 5, which ultimately increases cyclic GMP and causes smooth muscle relaxation and an increase in blood flow to the penis. With the classification, you'll often hear it referred to as a PDE5 inhibitor. That's that inhibition of phosphodiesterase 5 that I mentioned. Some other clinical practice pearls with this medication, the nitrate interaction, that's bound to be asked on an exam throughout your career. So, nitroglycerin, isosorbide dinitrate, isosorbide mononitrate. When this is combined with sildenafil, it can cause substantial drops in blood pressure. Okay? So that's a really, really important one to remember. Adverse effect profile. This medication was actually originally studied as a blood pressure lowering agent, so that is definitely one potential adverse effect. It could drop blood pressure potentially too far for some patients. And then there's been some rare changes in vision, color specifically. So that's something to look out for if patients report that. And then there's been reports of priapism as well. So those are probably the three biggest things that I've seen in practice, as well as might come up on one of your exams there. Next medication is Bactroban. Generic is mupirocin. This is a topical antibiotic. I don't have a ton to say on this one. Mechanistically, it binds to bacterial isoleucyl transfer RNA synthetase. Ultimately, this blocks bacterial protein synthesis. That's what blocking that enzyme basically does. Uses, superficial skin infection is where you're going to see it used most commonly. One important thing to remember clinically is deeper skin infections are going to require systemic antibiotic therapy. So you can't use a topical, or it's not going to be effective if you use a topical agent like mupirocin if there's significant depth to that infection. One other indication other than superficial skin infections, you may see it utilized in the prevention of infections, particularly associated with catheters and where they exit the skin, for example. So dialysis is a great example there. That's one indication where you may see this medication utilized as well. Adverse drug reactions, really not a ton there. Given its minimal systemic absorption, you're probably going to see skin irritation potentially as the most common adverse effect there. All right, and then the last for today, we've got number 75, and we've got brand name Januvia. Generic name is Sitagliptin. This is classified as a DPP4 inhibitor. Mechanistically, how does this work? Essentially, it prolongs the effects of incretin in the body. If you remember what incretin does, one of the many things it does is it helps promote fullness, or that sensation of fullness within the body. One important thing to remember, GLP-1 agonists are basically kind of incretin replacements. So using a DPP4 inhibitor like sitagliptin with a GLP-1 agonist doesn't make any sense. You're basically kind of using medications along the lines of a duplicate pathway, kind of similar to ACE inhibitors being used with ARBs. So that's an important thing that I've definitely caught in practice, where some clinicians have made that mistake where they use a drug like sitagliptin with a GLP-1 agonist, such as semaglutide, for example. So that's something that we generally shouldn't do, and guidelines recommend avoiding that combination there. Sitagliptin does have some dose adjustments with renal function. So usual max dosing is 100 milligrams. In patients with an EGFR of 30 to 45, max is 50 milligrams, and less than 30 mils per minute EGFR, max is 25 milligrams. Adverse effect profile. There is some evidence saying that in heart failure, these medications, this class of medication, may not be the greatest. Saxagliptin is the worst, so sitagliptin doesn't have the worst data within this class of medications. But I will say if you've got a patient with heart failure, you're probably not going to utilize a DPP-4 inhibitor anyway. You're probably going to utilize an SGLT2 inhibitor, which has kind of that dual benefit of managing diabetes, like sitagliptin will, but it also can help with heart failure. So, again, DPP-4 inhibitors have, kind of fallen out of favor because we've got a lot of other options that are generally better. So you've got metformin, SGLT2 inhibitors, GLP-1 agonists. Those are typically going to be used before a medication like sitagliptin. The other reason, in addition to maybe some of the adverse effects, is the lowering of the A1C is not as significant typically with sitagliptin compared to metformin, SGLT2 inhibitors, and GLP-1 agonists. So important things to remember there. Other things on adverse effect profile that I did want to mention quickly. Rare associations with pancreatitis and muscle soreness, arthralgia type symptoms. And from a hypoglycemia standpoint, typically this medication is not going to cause hypoglycemia by itself. Obviously, from a drug interaction standpoint, if we add on sulfonylureas, for example, there we may be a little bit more likely to run into a situation where we're inducing hypoglycemia because of the dual action of both of those medications. But by itself, typically you're not going to see a lot of hypoglycemia with sitagliptin. All right, well, I think that's going to wrap up the podcast for today. Do us a huge favor. Go support meded101.com/store. Your purchases there go directly to help support this podcast. We're appreciative of Freed AI as well for sponsoring this podcast today. Go check them out as well. If you want to track me down, Eric Christensen, PharmD, BCPS, BCGP, at mededucation101@gmail.com. And you can track me down on LinkedIn as well, of course. If you like the show today, do us a huge favor. Leave a rating review on iTunes or wherever you're listening. I greatly appreciate that. And also share us. Email us to friends, colleagues, message, Instagram, whatever platforms you're using. Definitely share the podcast. Help us spread around some pharmacology education. Thanks so much for listening. I'm going to sign off for today, and I hope you have a great rest of your day.